Okay, good afternoon, good morning. Thank you for joining us for today's webinar. We really appreciate all of you joining us for today. My name is Phil Breitenbuscher. I'm the Director of the National Family Drug Court Training and Technical Assistance Program here at Children and Family Futures. So I want to acknowledge that today's presentation is being supported by the Office of Juvenile Justice and Delinquency Prevention. And the points or views or opinions expressed during today's presentation are those of the presenters, and they do not necessarily represent those of the Department of Justice. So today we are going to have two extraordinary speakers on today's webinar. Dr. Nancy Young, who is the Executive Director of the Center for Children and Family Futures, the Director of the National Center on Substance Abuse and Child Welfare, who's been working in the field for many, many years, and of course, Dr. Norm Hoffmann, who is the President of Events Clinical Assessments. He's been in the field for over 35 years and has had more than 190 publications. And I'm really excited about today's presentation, and now I'd like to welcome and introduce to you Dr. Nancy Young.
Great. Thank you very much, Phil, and thank you, Dr. Hoffmann, for agreeing to be with us today. Part of the reason of, in some ways, revisiting this topic has been the increased number of technical assistance requests that we're getting from states and communities, and particularly states that are working with us in the OJJDP-sponsored program about how do you identify what is the best practice related to identification of families with substance use disorders. And so this is to really refresh in some ways some of the technical assistance products that we have developed at the National Center on Substance Abuse and Child Welfare some time ago, and then to have Dr. Hoffmann talk specifically about screening tools and what they accomplish, what you need to be focused on in selecting screening tools, and in particular the UNCOPE screening tool that he developed some time ago and has a lot of information about how that has been implemented in practice. Then I'll come back and see if I can weave that together in how to address the screening and assessment issues in child welfare and substance abuse treatment court collaboratives. So, and then we'll have some time for some discussion. So many of you have seen this before. When we think about the broader population of children of parents with a substance use disorder, the number we frequently use is this 8.3 million children. This comes from the National Survey on Drug Use and Health and has been analyzed 3 different times over the last 15 years or so to count how many children are there in the country that are living with a parent. In this case, the 8.3 million represents a parent who has who is classified as alcoholic or alcohol dependent, and or their parent needs treatment for illicit drug abuse. That translates to 11% of kids, and to make it a little bit more real to get a handle on that number, 11% of the kids would be about 3 in every classroom who going home to a parent who is alcoholic or needs treatment for illicit drug abuse. So when you think about that really very large number of kids in our country, and then to get a handle on what does that mean in terms of what child welfare practice has to do is part of what we're trying to clarify. Because then when we look at the alcohol and drug as a factor in the case in child removal, these data come from the AFCARS data set, which is submitted by states to the federal government each year, and it's specifically about children who have been placed in out-of-home care. And you see that since 1998, a steady increase in the rate of the alcohol and drugs as a factor in the reasons for removal. But you might think, gee, that 31% even in 2013 seems a little bit low. So what's going on when we look at that number in terms of what does that look like by state? And is it an identification issue Is it a data system issue? Is it a getting that item checked off in the box in the state's child welfare data? When we look at that 31% by state, it's sort of, I guess in some ways, surprising to see the great variation about what that looks like in state practice. I've been to every state. I haven't presented this in any state that they thought that the AFCARS data represented the true impact or prevalence of parents with substance use disorders in child welfare practice. Even in those states that you see a higher rate, still they would say that doesn't really capture. So we've, over the years, been able to distill a little bit about why that is. Why are the AFCARS data have such a variation, and what are some of the technical assistance tools that we can help a state or county or tribe use in order to better identify parents who need that second step of assessment. These data also create a bit of an urgency. When you look at those same data that we think are undercounting the impact, or at least what we hear anecdotally from practitioners, is that those AFCARS data don't represent the true prevalence in their state. But when you look at who actually has parental rights terminated, again, these are 2013 data. When we look at neglect as the #1 reason for removal, most folks would tell us that that's often the box that gets checked when it's actually parental alcohol or drug abuse as a factor in the case. But when you see that of the kids who had their parental rights terminated in 2013, almost 40% of them came from families in which the parents needed treatment for a substance use disorder. So we think that means that we've got some work to do. How we got to some of the technical assistance tools that were developed actually way back in 2002 and 2003, as we were just launching the work of the National Center on Substance Abuse and Child Welfare. Literally, it seemed as though when the announcement went out that the federal government had created the National Center, our phones started to ring, and they said, we can't change our whole assessment process in child welfare, but give us the 2 or 3 or 4 questions that we could ask and add to our screening protocol, and that would tell us if this parent had a substance use disorder, different terminology at that time, in 2002, 2003. But it was almost like, what's the silver bullet? How can we ask a small number of questions and then be able to document the case? Well, when we created and started to work on practice guidance on how to respond to cases involving parents with a substance use disorder, it became very clear that there were practices in place in communities and states, that there was a need for urgent attention to this. That you may recall at that point, we were just beginning to start the methamphetamine crisis of the increased rates of methamphetamine use. We were getting a lot of calls around that in the 2000s. And not unlike what is going on now in certain areas of the country in which opioids are the primary substance of abuse and of a use disorder. At that point, again, child welfare wanted to know, what can we ask in a very short period of time? And to be honest, the questions often came in a way in which it was, let us document our case. Let us be able to go to court and say, aha, I've asked those questions. Now I know this is a parent with a substance use disorder. And in many cases, it meant we didn't have treatment available. We didn't think we had treatment available. we needed to move to another plan of permanency if we could document that this was a factor. And as we got into this a little bit more, we did, again, learn from communities that had experience with this. We actually worked with Dr. Hoffmann and one of his colleagues at that point to better understand what is the process that needs to be put in place. What are the protocols that child welfare needs to develop that to partner with their treatment agencies, to clarify the communication that was needed, and to better have a way in which the focus shifted in this early effort from it's not just about documenting our case. It really is about trying to put a rational system for screening and assessment focused on how do you engage this family in services, how do you retain them in services, and how do you promote recovery among this group of families. And you see some of the basic premises that were developed from a very large work group that we brought together to say, help us understand how states and communities can do this in a better way. And that first premise is that it is the team that is perhaps more important than the specific set of questions. Dr. Hoffmann's going to give us some guidance on what those questions do need to cover. But it goes back to the value base and the rationale as to why we're asking these questions. Why are we trying to determine which parents need to go to assessment? How can we do that in a way that is really about family recovery? So some of these other premises that you'll see in the SAFER monograph, which is available at the website that you see, to download, and it is a guide about helping child welfare treatment and the courts respond to this issue of the need for identifying families in a way that recognizes no single agency can do this alone, that looking at substance abuse unilaterally or as only one factor is not the intent of child welfare. There are many challenges that families may come to child welfare practice with, but that although it's not a perhaps discrete package that you can say, aha, we've solved that one, that it really is an ongoing process of relationship building with the family, of uncovering the challenges, and meeting the needs that they have. So in the development of SAFER, as I mentioned, that this became a very strong effort of many different systems, primarily, again, child welfare, substance abuse treatment, and the courts, in an effort to focus on the outcomes that, again, not so much about, gee, can I document the case? And I will tell you that some folks came to that work group with that was the underlying principle that they were coming to the work group with. We need to document our case so I can put it into my court report and go to court and justify actions of removal, of an alternative plan of permanency, that it was very much the front end of, I hate to use the word sometimes, but the message and the exact words from a commissioner was, we need to get the goods on the parents so that we can put that into our case report. And in the participation with this cross-agency team and in the efforts that went forward to really understand what it is that we need to do together, it became clear that there were processes in place that each of the systems had already put in place to do this ongoing process, if you will. And SAFER, Screening and Assessment for Family Engagement, Retention, and Recovery, was developed to really understand this ongoing process that child welfare, substance abuse treatment, and the court already have in place to identify what is the presence of a substance use disorder and what is the immediacy. In treatment, there are systems in place that they answer these questions. In child welfare practice, they answer these questions around the safety of the child, on the risk factors that may be in place, and make that determination of what is the immediacy of the issue in very quick decisions sometimes that are necessitated to ensure the child's safety. The second phase of that then is understanding the nature and extent of the issue. What is the diagnosis? What is the extent in terms of the family's functioning? Are there risk factors that need to be identified and safety plans put in place to ameliorate those risks as much as we can? So the nature and the extent in substance abuse treatment is often around the actual substance use disorder and the implications in the person's area of life functioning. In child welfare, it's about how do we understand the risk factors that need to be addressed in our safety plans and in our case plans. If the child has been removed towards reunification, and if it is an in-home case, how do we put plans in place to ensure the child can remain safely at home? So this overall concept of the nature and extent are processes that each of the systems are going through at present. And finally, understanding how does that play into what is the case plan, what is the treatment plan, what is the response to the issue, how do we monitor and know that there have been changes made in family functioning and safety of the child, in the treatment of the substance use disorder, in restoring the person's level of functioning, and then is the family ready for a transition, particularly in those cases that the child has been removed. And finally, in monitoring, did the interventions work? So when we talk about SAFER, we're talking about these three broad concepts of is there an issue, and what's the nature and extent of that, and how do we develop performance measures and know that the family is ready for a transition? How do we monitor that? How do we monitor the success of the case plan? So we're going to talk a bit more about that in terms of how we bring that together. But we use this idea of the presence and immediacy in how the Child Welfare Agency ends up looking at that initial part of the early identification. Again, the screening of determining the presence of the issues, the assessment as a separate component which determines the severity of the issue and recommends a treatment course, determining the needs and strengths of parents and the children, what children bring to the case and the safety and the risk factors themselves, identifying the most appropriate treatment and other services, and how we ensure that there's not just a referral but a warm handoff to improve engagement and retention in substance abuse treatment. We like to think about this as moving from reasonable efforts, if you will, the letter of the law, to active efforts in clinical engagement. How do we go from here's a referral, a list of phone numbers, to actually ensure that our family plan, that our family engagement efforts are about engaging this family in this very difficult, sometimes, change process. Addiction is not easy for individuals. It's not easy on family members, and understanding that our focus is about engaging families in services so that they can safely parent their children and be in recovery in a way that heals their family is really the focal point. With that, I am going to turn things over to Dr. Hoffmann to talk a little bit and to give us those details about screening tools, and in particular the findings from the UNCOPE that he created many years ago. We appreciate so much still the efforts that he made many years ago to help us through this process, and we welcome you today to present that information, Dr. Hoffmann.
Thank you very much. Well, I'm going to back up a little bit from the screening itself to looking at some basics and some principles as well as diagnostic criteria. There's a persistent confounding of practices and terms. Screening and diagnostic assessment are often confused and are essentially mutually exclusive in a sense, although they're related. Screening is typically appropriate for conditions where there is risk, but which is not the presenting complaint. A thorough assessment is actually required for presenting complaints prior to treatment, as we'll discuss a little bit more. In general, the sequence would be a screen is positive, that triggers an assessment. The assessment then triggers a treatment plan. In some cases, there are things that come up that require deviation from that sequence. If the person is a danger to self or others, or is acutely intoxicated, for example, some of the assessment may need to be deferred until a later point. Now, with screen, oral or written, they should be fast, cheap, and easy to use. And that would be fast, free, or cheap, and easy to use. There are a number of free screens. Oops, we seem to be moving on without my tweaking here. And there are other more detailed screens. Most of those have some proprietary issue with them. We have one that we do on an annual lease basis. They should be able to be administered by any designated individual, and that you do not have to have a person certified for providing treatment in the area being screened. Ideally, a screen should have enough length so there's some flexibility in how it's used, but you should always remember that screens are just probability estimates. A screen does not a diagnosis make. All a screen does is indicate a relative risk for whether a problem is likely to be present, and then you have decision rules as to when that would trigger a more formal assessment. So screens should never be used as the sole basis for making any kind of a life-altering decision. A diagnostic assessment, on the other hand, while some structured interviews can be administered by technicians or appropriately trained paraprofessionals, the interpretation needs to be done by a professional who has expertise in the area that's being addressed. A diagnostic assessment should be as complete and definitive as possible, preferably orally presented in the case of substance abuse disorders and also mental health disorders. And it can incorporate multiple sources of information in the detailed assessment, especially when you're going on from the diagnostics then to the treatment placement. One way of thinking about screening versus diagnosis is oncology. I don't think anybody would suggest that a oncologist or surgeon should make a decision to do a radical mastectomy based on a mammogram. To dictate treatment, you need to do a biopsy, and you need to determine not just a diagnosis, but the stage of the illness. Are we talking about a stage 1 tumor or a stage 4 tumor? The difference, although the diagnosis may be the same in those two instances, the prognosis and the course of action can be substantially different. The goal of assessment versus engagement here, the goal of assessment is collecting accurate information. And in that role, denial can actually be your ally, both in screening and assessment, because many individuals, particularly those who have not encountered the system before, may not appreciate the implications of their behaviors and their experiences. For example, when I was in private practice, I had one client who reported losing a piece of most Saturday nights and felt that was quite typical. My favorite response, however, was the individual when I asked if anyone had objected to his drinking. He replied, "Well, of course, I told you I was married." As far as he was concerned, if your wife is not complaining about you drinking, you're probably not married. So in the assessment process, it's not necessary to get any engagement as far as being willing to understand or able to understand the condition that you're dealing with or to make a commitment to change. You do require the person to have some understanding of the condition involved and to be able to make some commitment to change. Okay, so when we're talking about outcomes, at least with regard to treatment, we're talking about achieving remission, which is defined by the DSM-5 as no longer meeting diagnostic criteria. For initial remission for a period of 3 months, and for sustained remission, it's a period of 12 months. When people talk about recovery, they're often encompassing many other things, having achieved a level of serenity and changes in one's life and the like. And recovery also, for many people, involves other things that may require other kinds of services above and beyond treatment, like in this case, perhaps parenting classes, vocational counseling, that kind of thing. So I think we need to be clear in our terminology as to whether what we're talking about is remission or recovery in a broader sense. The first 4 criteria of the DSM-5 refer to the person's relationship with the substance. The second 4 criteria address the issue of consequences of that relationship, like failing to fulfill role obligations, continued use despite social or interpersonal problems and the like. The last 3 criteria, if we can go to the next slide, cover issues of tolerance or physiological reactions, tolerance, withdrawal, and continued use despite having a physical or psychological problem. So those are the 3 groupings, if you will, of the DSM-5. Now, the DSM-5 diagnoses are determined strictly by the total number of positive criteria. And that is 2 or more is a mild, 3 or 4 is a positive, or 4 or 5 is a moderate, and 6 or more is a severe substance use disorder by the DSM-5. The ICD-10, which is going to be required, or is now required for billing purposes, still retains the dichotomy of harmful use versus dependence. And there are 2 versions of the ICD-10. The original one only considered the first item here, H1, physical or psychological harm. A research version of it, so-called research, which was developed later, included other kinds of impairments and dysfunctional behavior and adverse consequences for interpersonal relationships. Excuse me, next slide, please. The dependence criteria are 6 in the ICD-10. Many of them parallel the DSM-5. However, the dependence criteria number 5 here, preoccupation with use involving sacrificing activities and obligations, spending a great deal of time using and recovering, etc., is sort of a collection of things that are not necessarily one of the same, and it results in the fact that the ICD-10 might not come up with the same diagnostic severity level as the DSM-5 might indicate. Some of the other things like withdrawal tolerance and the like are exact matches. So if we would consider more of a generic criteria, then we would be able to reconcile these two together. Now, as I mentioned, the ICD-10 is really based on an old consensus. The DSM-5 is based on a newer consensus, considering substance use disorders on a continuum. So out of the 11, if you have 2 or 3, you're mild. If you have 4 or 5, it's a moderate. And if you have 6 or more positive findings of criteria, then it classifies as a severe substance use disorder for whatever the substance is. I should point out that there's no sound, rigorous empirical evidence to justify either diagnostic formulation. And in fact, this is true for much of the DSM-5, that it is essentially a consensus document. It is not a rigorous, scientifically based document. That in the case of substance use disorders, I know of no rigorous research that suggests that, for example, the cut between moderate and mild should be 3 versus 4, or that severe should be defined as 6+. And in fact, in the very first iteration of the DSM-5, severe was defined as 4+. So keep in mind that some of this is more art than science. There's some other pragmatic considerations as to what you want to use and what kind of documentation you wish to employ. The American Psychiatric Press has been known to demand payment for using the DSM-5 diagnostic codes in either clinical records or electronic record systems. This has caused one state to essentially dump the DSM-5 entirely and is going strictly to the ICD-10 as far as the substance use disorder issues are concerned. In any case, the ICD-10 diagnostic codes are required for billing, and the DSM-5 and ICD-10 diagnoses, contrary to what is implied, do not necessarily match exactly as suggested by the DSM-5 manual. We have found, for example, that for certain substances, those with a moderate diagnosis do not necessarily fall into the severe range as indicated by the DSM-5. It tends to range somewhere between 60 to 80% of those with a moderate do in fact get a severe diagnosis, but that still leaves a minority of cases that don't match up correctly. The other thing that nobody seems to be talking about all that much, or few of us are talking about, is that the criteria do not seem to be all created equal. That is to say, some criteria are found almost exclusively among those with a severe to moderate substance use disorder, while other criteria are more common among the mild to moderate substance use disorder groupings, and in fact, a few of the diagnoses are not all that uncommon among those who don't have a diagnosis at all. We've published these findings in the next slide that shows the references for it, so people can pull up the references should they wish to look at it. We won't belabor this slide, but go into the next. I just point out that the findings we have found apply to alcohol, cocaine, cannabis, and they seem to apply to adolescents as well as adults. Now, if we're looking at generic criteria, these 6 are split up by those criteria that seem to indicate a more serious problem. The D and C designations refer to dependence as defined by the ICD-10, or C as a criteria of the DSM-5. So we have craving and compulsion to use, which the DSM-5 lumps into one single criteria actually, a desire or inability to cut down and stop, failure to fulfill role obligations, and sacrificing activities due to use or because of use, and withdrawal. The next slide has the, in this case 6, because we split one of the DSM-5 categories. These are found also among those who have severe problems, but also are more likely to be found in greater prevalence and scattered among the various diagnostic groups. So unplanned use, spending a great deal of time using, social or interpersonal problems, hazardous use, that is to say use in situations where use or impairment could be hazardous, and medical and psychological problems. Now you'll notice that has 3 designations, because while it indicates harmful use as defined by the ICD-10, it also comprises a criterion for dependence. The difference between the 2 there is that for harmful use, the problem just has to have occurred, whereas for the dependence criteria to be really strictly met, the individual must know that the problem has been caused or exacerbated by use and still continues to drink or use the substance. This is a slide showing the distribution of those with a positive finding on a given criterion and how they distribute. And as you can see, these set of the first 6 items here correspond to a moderate to severe diagnosis in almost every case. The far right column gives the overall prevalence. So you can see the prevalence for these in general tends to be at 25% or less for most of them, and includes that first set of criteria that I mentioned before. Virtually none to very few are positive and fall into a no diagnostic group. The next slide will give us the rest of the criteria. And here we see the prevalence rates on the far right-hand side are much higher, but the distribution is across a broader range of diagnostic formulations. For the males, you see tolerance when positive is endorsed by, when positive, 13% of those who are positive on tolerance actually don't have a diagnosis at all. For dangerous use, it's 9%. And legal problems, which was deleted from the DSM-5 as a criterion, also follows that same kind of pattern in that it's non-specific. I think part of the problem with tolerance is that tolerance is determined by your use level, not necessarily your diagnostic. So that somebody who drinks a lot and drinks a large amount of alcohol is likely to develop tolerance irrespective of whether that causes a problem or not. Similarly, dangerous use may be an amalgam of more than one thing. It may be thrill-seeking or impulsivity, and other personality characteristics might enter the equation so that people use in circumstances where it's dangerous, but not necessarily because it's a substance use disorder per se. The next slides, 2 slides, show us the same results for a group of females. Again, we see that for that first set of criteria, no more than 1% of people who are positive fall into the no diagnosis group. And in the case of compulsion to use with this particular sample, all of them fall into the moderate to severe. And again, most of those are in the severe, beyond moderate. The next slide has the other set of criteria, again following the same pattern, which is a higher prevalence rate in general, and tolerance and dangerous use, as well as the legal problems, which was deleted. When positive are not unusually found in those people who don't have a diagnosis at all. So if we can go on from there, we will hit our Big 5 group. We have termed these 5 criteria of the DSM-5 as the Big 5. Wanting to cut down and setting rules, craving or compulsion to use, failure to fulfill rule obligations, sacrificing activities to use or because of use, and withdrawal. These 5 criteria are the ones that seem to indicate a much more serious problem than the other 6 criteria of the DSM-5. The next slide gives a little background on these. They reflect the concept when I started doing research in addictions 30-some years ago. Loss of control was the big buzzword at the time. And I think that's what these Big 5 referred to. That is to say, loss of control is the construct that if you begin using, you do not necessarily have the capacity to moderate or stop. For the three substances we've researched at this point, alcohol, cannabis, and cocaine, all look essentially the same in terms of distribution and the statistics that are associated with them. And they may indicate individuals, I think, who are actually qualitatively as well as quantitatively distinct from the milder substance use disorders. And we're now in the process of looking at the moderates to see if it is indeed the big five that make a discrimination between the moderates who also get a dependence diagnosis with the ICD-10 versus the moderates who do not qualify for a dependence diagnosis. The hypothesis being that if you're positive on the big five, you're going to be in dependence, and if you're not, if you have no positive findings on any of the big five, but still hold a moderate diagnosis, that you might be able to moderate your use. For those who do hit the severe diagnosis on the DSM-5, abstinence is most likely going to be essential for any kind of remission to be achieved. That is one of the positives, I think, of the DSM-5 is that, in my opinion, it clearly defines a group that needs abstinence in order to achieve remission. But it also probably indicates if you have a mild or maybe even a moderate with nothing positive on the big five, then moderation might be an option. So I think one of the things that we have with the DSM-5 is an opportunity to look at whether or not we can make a discrimination between those individuals who might be able to adapt or modify their use as opposed to those who will not be able to do that. Okay, so now let's get down to the screening assessment issues. When to screen? Well, when your time is limited is an obvious one, but the condition is likely to be present. In many cases, the screen is most helpful in eliminating areas from further consideration, that we don't need to worry about that. So, for example, in an addiction program, you might screen for mental health issues, and if you don't find them, that's fine and dandy. You can then concentrate on the substance use disorders. The same thing would be true, the mirror image in the mental health setting, where a negative findings on addictions means that that's not probably a likely problem area that needs to be addressed. You also screen when a full assessment is not necessarily required. In the case of welfare screenings, you would not necessarily expect welfare workers to do full assessments. They may or may not have the qualifications to do that, but they can certainly do the screening. Now, screens are typically used for what's not the presenting complaint, because if you have a presenting complaint, then the screening has essentially already been done in one way, shape, or form, and you need to move on to a formal assessment. So, for example, the DUI offenders, it's not so much a matter of screening, but you need at least a triage to a full assessment, because the very fact that the individual got a DUI is a de facto screen, and that they're indicating that there's some risk. What we in fact find with regard to first-time DUI offenders is that about half of them will pull a DSM-5 diagnosis of one kind or another, and the other half would be what I jokingly refer to as the B code is zip damn fool, which is the group that the only thing they have done wrong is they have drank too much and been driven. Now you have excuse me, formal screens and you have de facto screening, as I alluded to with regard to DUI offenders. A de facto screen involves an observations that are so obvious that they indicate that an assessment should be made. So if a parent is found acutely intoxicated with many empty liquor containers around and children are being neglected or endangered, I don't think we need to mess with a formal screen. We already have enough evidence to suggest that an assessment is probably warranted. The same thing would be true if you found drug paraphernalia and observed track marks on the parent's arm. It's not a matter of whether there's a risk or not. It's a matter of what is the diagnosis. The UNCOPE was developed initially from a very large sample of people in treatment. The items you see here: have you ever spent more time drinking or using than you intended? Have you neglected responsibilities? Have you tried to cut down on your drinking or drug use? Have anybody objected to your drinking or drug use? Have you found yourself thinking a lot about drinking or drug use? We prefer that wording to preoccupied because some people, quite frankly, don't know exactly what preoccupied means. And have you ever used to relieve emotional distress, such as anger, loneliness, or boredom? The exact wording of these items doesn't tend to make a lot of difference. You could say, have you drank more than you intended? And that'll get you about the same thing as if you've spent more time drinking than you intended. The UNCOPE is also flexible in that you can use it in this wording as a general screen, or you can focus on a specific substance. Have you spent more time drinking, drinking this, or drinking with problems with drinking, or you can focus on a specific substance. Have you ever spent more time smoking pot than you intended? Have you ever neglected your responsibilities when you were smoking pot? So on and so forth. So you can focus it as a substance-specific screen. You can use it as a generic screen, and it seems to work as well for adolescents as it does for adults. And again, many of these screens that are relatively good, the exact precise wording doesn't necessarily matter much in general. One exception to that is the question on the MAST, which is a screen I use as an example of how not to do screens. There's a question on there, at least in the original version of the MAST, of have you ever attended an AA meeting? That question caused every graduate from the School of Social Work at the University of Minnesota to score positive on the MAST, because attending an open AA meeting was the task for one of the required courses. It didn't stipulate that you go to an AA meeting because of concerns about beer drinking. So in that instance, the difference between the right and wrong word, as Mark Twain said, is the difference between lightning and a lightning bug. But in general, the wording doesn't matter much. There's the instrument of craft, where the first item, it asks about whether you've ridden in a car with somebody who was impaired, which could be a problem in urban settings where a lot of youth may not have cars. And then there's always the tool that the SAMHSA has pushed for years, which has been a concern of mine, which is the ASI, which was never an assessment tool, but really a program evaluation tool, since the ASI has no diagnostic information that's helpful. Well, it has no diagnostic information, period, and it has minimal clinical value other than perhaps whether the person has had suicidal ideation. Now, the UNCOPE conforms, this is the bit of the history and the location where you can find it. It was initially developed on a sample of about 40,000 treatment intakes, indicating those individuals with the dependence diagnoses, based largely at that time on the DSM-5. The final UNCOPE wording was validated using arrestees and subsequently state prison inmates as well as juvenile in the detention centers. So the UNCOPE has been validated on on populations that typically tend to be very defensive and guarded. So we feel that it probably will work in many other settings as well. And in fact, the UNCOPE is also being used not just in child welfare types of applications, but also things like the SPURT programs, where they are doing the screening and brief interventions for patients in medical practices. Again, the wordings tend to have, in general, a minimal effect on the sensitivity and specificity. We also developed for that latter use with medical patients, the UNCOPE-Plus. Well, let's go with this first. The UNCOPE maps to 5 of the DSM-5 criteria, 5 different criteria. The E item, the last one, implies some self-medication. But that's one of the reasons that the UNCOPE is unlikely to produce a false positive, because you actually are mapping to 5 of the 11 criteria, and the 3 of those, the N, the P, and the C, correspond to items in the Big Five. We can go to the UNCOPE-Plus slide. What we did there is we took the UNCOPE and added 4 items on quantity and frequency of alcohol use, including whether you drink 5 or more drinks or 4 or more drinks, depending on gender, and then frequency of substance drug use. And what we were doing with the UNCOPE-Plus, which is also located on my website if you want to get it, pull it up, it's free, to help in identifying those individuals whose use might be problematic but not necessarily diagnostic. So whether you use the UNCOPE for strictly picking up diagnostic information or the UNCOPE-Plus for also flagging those individuals who might be using this inappropriately, either screen will work. Okay, now scoring is pretty simple. It's a matter of adding up the number of positive responses, at least for the UNCOPE itself. With regard to the plus, I have developed, and it's on the website, some ideas on how to provide feedback for excessive use or too frequent use and that sort of thing. Now, the cut score that you develop, the cut score is that score above which you consider the case to be positive or requiring an assessment. Is set by whatever the organizational decisions, priorities would dictate. If you have a low cut score, you won't miss many. You'll have high sensitivity, which is sensitivity being the proportion of people that you correctly identify as having the problem, who do have it. But in doing so, you're going to also get more false positives, which need to be ruled out. If you set a high cut score, then you'll reduce your false positives, but you'll get more false negatives. Now, the seriousness of the error may depend on whether you want a balanced approach or whether you want to minimize or maximize sensitivity and specificity. And that is a decision that is not a scientific one, but a programmatic one, depending on the seriousness of the error that you're going to be making. So sensitivity is that proportion of true positives who are identified as positive or at risk. Specificity is the proportion of people who do not have the condition identified as not having the condition. Sensitivity and specificity are not affected by base rate. The screening yields are defined by base rates, but the sensitivity and specificity are independent of base rate. Now, as I mentioned in the previous slide, if you increase one, you decrease the other. And this is true for any given screen. It's not anything that you can do anything about. You cannot simultaneously increase sensitivity and specificity on the same screen. If you increase one, you decrease the other. If you decrease one, you increase the other. So there's not much you can do about that. What we have found on the apparent sensitivity and specificity of the UNCOPE is that if you consider a positive as having 2 or more of the 6, you will find about almost 90% of everybody that has a moderate to severe diagnosis. We're ignoring mild in this case, and the specificity will be about 91%. If you boost the cut score to 3 or more, then you will find about 3/4 of all the positive cases, but you won't get, essentially you get no false positives. So again, if you were to lower the cut score, you would increase your sensitivity probably to 95%, but your specificity would go down, so you would have a lot of false positives to sort out. Now, where your base rate does come into the equation is in the issue of the cost of ruling out those false positives. As I mentioned earlier, the UNCOPE covers 5 different DSM criteria, so that if you get a positive score of at least 3, by definition, the person is likely to meet at least a mild diagnosis because you will have 2 positive criteria indicated by the UNCOPE itself. So as to whether you're concerned about mild, moderate, or severe, or only severe, that again is a decision that you would need to make as to what's important for the particular purpose that you're doing the screen using the UNCOPE. So what's the cut score you want to use? Determining the cut score is, as I mentioned earlier, and I had a teacher once who said anything important is worth repeating. It depends on the priority you have. If it's a very high cost issue to miss anybody, you want a low cut score, but then you're going to have to sort through some false positives, and that may have a cost associated with it as well. If you want virtually all your positives to be true positives, then you use a high cut score, but it means you're going to miss more cases. So we can go to the next slide there. So the bottom line there is this is what we would call an administrative decision, not a science one. That it depends upon what you consider to be the consequences of making a mistake. So if the cost of a false negative is great, then you would want to set your threshold low and deal with having to sort out false positives. Now there is one way of improving upon this, and that is to use a triage tool. A triage tool is one that covers all of the DSM criteria, but minimally, and gives you a better definition of what it is you're dealing with. But for your purposes, those tools are not free and do engender some cost. So there are also factors that are going to affect your screening capabilities. One of the things we found in correctional populations, for example, is that if an officer in uniform asks a question, they don't give good answers. We have actually published a study that compared the answers given to an officer in a jail setting versus the answers given to a neutral person who is doing a study, and we find that the neutral person gets twice as many positive responses as the authority figure in general. If you want good, honest answers, the individual asking the questions or presenting the written screener should be viewed as somebody who's either neutral to supportive and not viewed as somebody who, for example, has the authority to remove children or something like that would be the possible implications for this application. The timing of when you do it is also important. It could be too early, too late, or just right, just like Goldilocks. Criminal jail settings, doing it at the time of booking is not a great idea. Waiting until the person's about to leave is also not necessarily going to do much good for you. But the optimal time seems to be a day or two after booking, when the person has settled into the routine and is no longer as upset and distressed about having been arrested. In the case of child protection, there may be analogous timing issues here of doing it as soon as the people walk in the door, as opposed to waiting until there's some rapport established, and then maybe also not before the issue of actually removing children comes up. And so there may be a sweet spot in there as to when the best timing for doing the screening will get you the best information. Another issue is competing activities, and this goes along a little bit with the timing. So if you're doing it during the booking process, for example, there's a lot of other things going on. The individual's all upset. You know, there's maybe all kinds of other issues that need to be resolved. Whereas if the person has settled into the jail routine and is calmed down a bit from having been busted, that's a better time to do it. Again, if there are all kinds of other things going in a child protection investigation, that might not be the optimal time to do the screening. I'm not an expert on child protection, so I cannot give you much guidance as to when to do it, other than you do want to have it when the individual has some tranquility about them, and when things are not in an uproar. Another thing is the setting, if it's private or public, or whether the individual feels safe or feels exposed, just being honest. So you want to have the screening done in an environment that lends itself to the individual being candid and not feeling threatened or endangered in any which way about that. Now, your administration options can be, with the UNCOPE, can be verbal or written. We have used it either as a freestanding verbal screen. We have seen it used as part of a longer information gathering process. It can be woven into a questionnaire or some of the paperwork that people typically fill out on admission to treatment, or in situations where they're filling out information about whatever the circumstance involves. The administration can be done by anybody. A screen that's properly done does not require a trained professional in the area being screened. And in fact, a properly designed assessment tool can also be administered by people who don't necessarily have all the credentials in all the areas being covered if the instrument is properly built. It's a matter, there's a difference between the administration and the interpretation. The interpretation does require a qualified professional in all instances. Now, there are limitations to screens as well as everything else. There isn't a screen on the planet that's 100% accurate. I actually don't know of any screen that's accurate on 95% of the time. But even if you had one that was accurate 90% or 5% of the time, on average, you'd still be wrong once out of every 20 cases. So keep in mind that no screen is perfect, and even the best of screens will still make a mistake at least once every 20 cases on average. So that's again why I've been stressing before that no life-altering decision should be made on the basis of a screen, because you're only getting a probability guesstimate with any screen. Is there a likelihood that we have a problem? And if there is, we should get a full assessment and make judgments based on that assessment, not on the basis of a screen alone.
All right. Thank you so much, Dr. Hoffmann. We really appreciate the detail, and I think you were able to raise many of the questions that folks in child welfare practice have about how to implement a screening tool. Some of the questions about when and by whom. Those questions are in part how we ended up with the monograph that we refer to as SAFER, really being a collaborative process that we're trying to help communities through that process, because again, it's the team. We can see in the data that you presented, particularly about the parallel in a criminal justice setting, that the purpose of the screen becomes so important. Again, is this helping to engage the family in this change process, or is it administered in a organizational culture of I'm trying to document my case? And that is more than simply saying there are these 5 questions, go implement them. Because the protocol about when and by whom and where the information goes and how that partnership plays out with the substance abuse treatment becomes so critical. Some of the questions about, is this something that you would do at an emergency response kind of level? Probably not, but you would probably want that emergency response worker to be looking at signs and conditions in the household that allows that person to say, gee, this is something that I've observed in the household. Do I need to even do a screen during the investigation phase after I've made some initial safety decisions? Or is this a referral for an infant who has been detected with prenatal substance exposure? You probably don't need to do a screening tool. You could move on to ensure that the treatment agency is engaged in creating an assessment for that particular mom. So some of those other factors about when to use a tool we believe really needs to be made in partnership with your substance abuse treatment agency at the state level, to have that input, at the community level, to have your providers on board. They're grappling with some of these same issues between DSM-4 and ICD-10 as they're looking at billing codes, and understanding how they're using those criteria of a substance use disorder is paramount in child welfare practice, to understand what the case plan about how we help that family, how we help that family member really enter remission and manage their disease means that that needs to be done in a partnership. So what have we found when states have implemented a screening tool? You may recall early in the presentation I showed you that bottom line that said in the data that are submitted to the federal government from the states, the trend has been increasing, and across all of the states, 31% of children that have entered out-of-home care have the boxes in the state SACWIS system checked that says alcohol or drug was a factor in the case. The line just above that is from the state of Maine that implemented the UNCOPE in about 2007. They happen to have been working with us in a program of in-depth technical assistance that they were looking at their screening tools, and they developed a protocol that is implemented in the investigation phase across their states. The higher one is the state of Alaska that around 2006 implemented their own screening tool. They look at many different factors in that screening tool. There are 37 items with a broader aspect than just the substance use disorder. They're also looking at domestic violence, mental health issues. But you see what happened in both of those states when they put in place practice and policy, the protocols for workers to engage with treatment agencies to make sure that screening was in place, that it was documented in their data system, which are very much two separate issues. Screening can take place and it doesn't get into the electronic record, which makes it then very difficult to do statewide, countywide, regional planning if you're not getting that into the electronic record that are able to look at that over time for creating systems change. So the safer intervention, if you will, says that we need to build this system of collaboration, that there is a structure that needs to be in place to have the communication happen at the state or the local level, that it's focused on sustaining that change in activities that change practice at the line level and are reinforced in a way that the collaboration is able to communicate both at the worker level, what's happening with a particular case plan, and at the broader system level, what does that mean for our overall data in terms of the need for resources to address the substance use disorders, as well as to monitor what is happening after these kinds of systems are put in place. So the safer intervention deals with each of these three different areas to help create a plan about moving forward in each of these areas with some tools and some suggested guidance about how to get started. The guts of the document is a little bit shorter than the actual appendices. So those tools are in a facilitator's guide. It gives you actual templates and exercises about how to create the communication across the agencies, a series of fact sheets that we recognize are a bit out of date. You probably could find more recent things on the National Center website, remembering that SAFER was first published in 2007, so the more recent data. And understanding what that means in terms of the needs of children, how the substance use disorder affects parenting and child safety, as well as potentially the prenatal exposure for the child, neurodevelopmental complications that the child may have, other factors that need to be put in place to understand the needs of the children themselves. Then there is a lengthy appendix, which are actually the screening and assessment tools for substance use disorders. This is work, again, that Dr. Hoffmann and his colleague did with us to, at that time, really understand what are the screening tools that were in play in substance abuse treatment agencies. And I just am briefly going to run through those slides to give you the idea that there are many of the screening tools that are listed. We, as you can tell, happen to like the UNCOPE. We've seen it implemented successfully in child welfare practice in partnership with agencies. But there are other tools that were available in 2007 that your local jurisdiction may say we need to look at some of these other kinds of tools. So you see them all detailed in the appendices, as well as the assessment tools. Gives you information about each of them, how you can attain those assessment tools. What's important, we think, about this is understanding what your substance abuse treatment agency is using right now. Child welfare doesn't need to recreate the wheel on that. This can give you some of the terminology, some of the strengths, some of the challenges with any of the tools, but we want really to encourage that you're working with your substance abuse treatment agency so that you know what they're using. What are the tools that are in play in your state right now, in your communities right now? Because as we started with, these systems are in place about screening, assessment, case planning, and monitoring in the various systems now. Our hope is that you have an environment in which this partnership can help you determine how does it work now, what changes need to be taking place so that we're able to do that with more efficiency, and how do we communicate that across the system. Back to the appendices, some of the basic terminology, as well as the National Institute on Drug Abuse Principles of Effective Treatment are in the appendices. And then what are common tools looking at safety and risk assessment that child welfare staff has? We recognize that the treatment agencies need as much of this information from child welfare as child welfare needs from treatment. And in fact, the treatment agencies need to understand what do you mean by you're doing a safety assessment? What do you mean you're looking at risk factors? What are those? What are common tools that child welfare uses? And we hope that this would be helpful in your dialogue in your communities. An appendix on appendix on sharing confidential information. What does a consent to share information need to entail? How can you, again, streamline that process so that we can reduce the noise between the system and increase the communication? A glossary, and then some specific information that's important about the Indian Child Welfare Act and the requirements of ICWA in child welfare practice, and in particular making sure that treatment agencies who may be much less familiar with that have information about what does that mean when they're working with Native families. So all of those appendices come together in a way that says the model of SAFER, screening and assessment for family, engagement, retention, and recovery, builds on a structure of cross-system collaboration. It establishes the individual and the cross-system roles and responsibilities. Who's responsible for doing the screen? Who's responsible for doing the assessment? What information needs to be shared across those two areas? Who's responsible for the case plan? And when there's been changes in the case plan, who's responsible and whose role is it to notify and to work together across the agencies. A section on identifying the frontline collaborative practice. What does that mean, again, for workers? What information do they need to know? What information needs to go from the initial investigation phase to the treatment agency and vice versa, and then in a way that these items of information that are being communicated are focused on the joint accountability across the systems to produce better outcomes. When we look at the Child and Family Service Review outcomes in standard practice compared to those places that have put systems in place to identify and to engage families in treatment, those families do better than standard services. So how do we really pull this together in a way that we're focused on the remission, the recovery outcomes? How do we monitor that? How do we define that? At the same time that we're focused on the child welfare outcomes of safety, permanency, family well-being, and family recovery. So we think about this structure like this. This came about after a few rounds of the National Center's effort in in-depth technical assistance. And to be honest, in the first round we said, how are you going to organize yourself to do this work? And some states said, oh, we don't need to have this kind of formal structure because we know everybody. We're a small state. We know everybody. We can just call up our colleague and we can get things done. What we found after we said, okay, we'll go with that. You have the informal structure. You don't need to have this structure of saying that there are rules and responsibilities and roles that are clarified. And in the second round, we said, okay, we're not going to do that anymore. We found that communication didn't happen and that we need to make sure that there is a formal structure of who's in charge at the director level, how often do they meet, how do they ensure that there's long-term sustainability in these areas, particularly in the screening and assessment and monitoring the outcomes, who's the core team, who's able to look at the barriers that might be coming up from counties or regions and remove those barriers, and what work groups need to be put in place to bring their expertise together to solve some of these questions. That structure has proven a few times over, actually many times over, to be an effective way to structure the practice of collaboration so that we can get to that better communication and better protocols between the systems. So let's go back to, remember I said that there's some concepts that are already in place. Now, I don't mean to suggest that anybody in substance use treatment agencies would say we're going to do an immediate need triage, but in fact that's what they're doing. They're saying, is this a person who is at risk of overdose that we need to have an immediate response to? At the same time, child welfare is saying, is this a child who has such safety factors that means that child needs to be removed right then? The court is holding a preliminary protective hearing. These are systems that are currently in place. What we're asking you to do is to understand what that system looks like in your community, working together across these three primary systems, understand what they call it, what's the terminology, what's the process, and then importantly, what does child welfare and the court need to know from the substance abuse treatment agency, and vice versa? What does the treatment agency need to know from child welfare and from the court that have these processes in place? So when you look at what is the immediacy, what's the nature and extent, all the way through this model of what happens in a case plan, what is the response, how has the family demonstrated change, is the family ready for a transition, either for a permanency decision for reunification or a concurrent plan of another permanency determination. How do you make those assessments of is the family ready for transition in partnership in a team? And then finally, what are the performance measures, the outcomes that this collaborative is focused on to understand, did that intervention work? This comes together in a way that says each of the agencies then needs to establish what is their role and responsibility. What is the treatment agency's role? How do they know if a child may be at risk that they must respond? How does the child welfare agency understand the basics of substance use? And importantly, it's not, as you all are aware, not just the substance use, but how does that affect the child's safety and potentially the child's developmental trajectory? So in each of these areas, we ask you to understand the role, the responsibility, how that plays out in the screening and assessment, and how collaboratively across those three systems, there's a communication protocol put in place that communicates this information across the agencies. That frontline collaborative practice then that says that the three systems have developed a practice protocol and they have policies and tools in place to understand who screens, answering that question of is there an issue and what's the immediacy, who does the assessment, is there a diagnosis that can be made, how does it affect the child maltreatment, and how do we understand what that means in terms of the collaboration in the case planning in order to monitor their progress and evaluate outcomes. That development of the frontline practice is what needs to then be sustained in the practice protocol and in policy. Some ways in which we've seen communities come together in creating a strategy for screening. In many jurisdictions, there's a substance abuse specialist who accompanies the worker on their first visit during that investigation phase. That is a model that is in practice in many jurisdictions, Los Angeles and Kentucky in particular, where we have been working and know of how that plays out, that the substance abuse assessor goes with the caseworker during the investigation. So it removes that here's a person in authority who's making a determination of if your child is going to stay at home today, to a person who is really focused on the change and engagement that needs to happen to address this substance use disorder. Substance abuse counselors assigned to the investigation workers, units rather, that practice has been in place in Florida for over a decade. And then some other ways, some variations about the screener that goes out on the first visit, and then they make this warm handoff, meaning that it's not just a referral to a phone number to the treatment agency, but in Vermont where they're making a warm handoff to ensure that the parent can get to the assessment and that the communication is happening that's needed. You saw some of the data on the universal screening, that every case in Maine and Alaska and some various pilot sites that they have put in place a universal screening tool and protocol. But we recognize that again, we mentioned some of these issues that Dr. Hoffmann mentioned. If you go into the home and there are, don't probably need to go through a written or a verbal UNCOPE screen, but there may be some other indicators that you want to have some training in your investigation unit to ensure that this is going into the information that goes to the substance abuse assessor. This is what I observed when I went to the home. This is what we need to have an assessment to determine the extent of the substance use, and if there is a substance use disorder that requires treatment, what is the level of care that is needed that the assessor needs to determine. So again, the communication that becomes so critical in understanding how do you communicate that in an efficient way to the substance abuse assessment, so that that is not apparent that we get this oftentimes this question about, well, what happens when the parent just denies? Well, are you giving the information that you have to the substance abuse assessment agency? Because the substance abuse assessment can use that, as Dr. Hoffmann was suggesting. I don't know if this is accurate, but this is what the Child Welfare Agency has told me. Let's see if we can delve into that a little bit and understand why that might be in this case record, and use that in a way that it's an engagement. You no longer need to deny to me. We're not asking you those direct questions right now. We're trying to understand why child welfare has this in their documents, and that becomes almost the third party that you're building the alliance with the person, the parent. You're building that relationship, you're building that professional alliance to understand what's the extent of their substance use and can they engage them in this change process. And by alliance, hear me very clearly that it's a professional alliance using motivational enhancement strategies to engage that parent in a way that they are recognizing their own goals and establishing those goals with the substance abuse counselor. Other ways that we've seen this be put in place, many jurisdictions now have a substance abuse counselor that are based at the court, so it may not have happened during the investigation phase, but it may actually be at the very first preliminary hearing, or some call it the shelter hearing, or that 72-hour hearing, that there is a person who is at the court who again is engaging that parent in providing the safety that the parent needs in order to engage in this treatment process. There are a couple places that the parent's attorney actually employs the counselor for putting them in having access at the court, so that their role is to engage this parent in treatment. And in many jurisdictions, there are contracts in place between the Department of Children and Families with substance abuse agencies to provide that intervention and engagement service. And Arizona is one of the places that has had that in place for quite some time. Other ways that we've looked at the reporting back in that collaborative case planning, that there is a protocol about what needs to be communicated that is established in policy, so that the monthly report, or in this case in Connecticut, Sacramento County, Riverside, many places now have this standard protocol that twice a month information about the parent's attendance, their engagement in services, their drug testing, how that is happening and what the results of that are, that's being communicated on a regular basis to the court and to child welfare workers, again, to reduce the noise and to increase the communication, and presented to the parent, and importantly to the parent's attorney, as a way that they're providing evidence in their case. This is their opportunity to have a voice. We're going to be able to report twice a month on how you're doing. Obviously, if that's going very well, the parent wants you to have that information. If it's not going well, the court and child welfare needs to have that information also, so that they are able to take action if needed to ensure that the child is safe if it's an in-home case, and to be making permanent plans for that child when needed. It's done in an area of safety and a premise a value base, that we're in this together, that we are not separating the parent from the child in the way in which we look at family-centered care, that we do it in a way that we are, again, engaging the family. And in many jurisdictions, the move towards having either administrative or court hearings much more frequently than what standard court hearing practice would be, which would mean have a disposition and a jurisdictional hearing in the case, order the case plan, and perhaps the court doesn't see that parent again for 6 months. We know clinically that makes no sense. Waiting to ensure that the parent got to treatment, that the barriers to treatment were removed, that the parent was able to be in this change process needs to happen much more frequently than waiting 6 months to determine what the aftermath of this engagement process has been. So again, many jurisdictions that are looking at different ways, either through a formal family drug court or other methods of having reviews about the recovery component of the case to ensure that parents aren't waiting until the 6-month court hearing to have anything communicated about how that recovery component of their case is going. Now, this may look like a hodgepodge of a lot of gunk, and in some ways it is until you get into the fine-tuning of it. Until really just this last 6 months, these templates that are part of the SAFER document were the most downloaded items on the National Center website. And we have a few hundred thousand contacts with our website a month. And this was the most downloaded document. What it says is, remember when I was talking about that screening, the immediate need triage, the in-person safety assessment? What this work group helped us do in the creation of the SAFER monograph was to give some suggestions about what needs to go between the systems in being communicated. So this one is at that immediate need triage, the very first safety assessment. Again, it's who needs to know what. These are suggestions of the what and the direction that the communication needs to go. They're not meant to be all-inclusive for your community. They're meant to be suggestions. What is it that you want to have communicated to your child welfare worker? What is it that the treatment agency needs to know at each of these phases? So this one is at that initial screening and the safety assessment for the child. This one is at the part of the system that is about developing and monitoring the case plans, about what's the assessment, what that in-person risk assessment looks like. Again, it looks like a hodgepodge of a bunch of arrows and a bunch of bullet points. It is. But there's suggestions for you to get into the guts of that and say, this is what we need to know at this phase in the case plan. This is what needs to be communicated. It's a way to say, just don't send me a long report that my worker and the judges and the attorneys frankly don't have time to read. This is the most important information that we need to have from treatment. The treatment agency can say, this is the most important information I need from child welfare worker and from the court when there are court hearings. How does that communication go back and forth between the systems? And then finally, when do we know that there are opportunities for changing levels of care, moving on to permanency, how we monitor outcomes? What are those data items that need to be communicated at the case level? And then how do we roll that up to look geographically or program specifically about how we have increased the communication and decreased the noise between our systems. We didn't expect when these charts were being created that they would find such utility. Again, it is the collaborative process of working with your treatment agency and your court staff and the child welfare staff to say this is how we do it in our community right now. Now let's figure out what we're already collecting and what we need to communicate across the system. One of the things that we've used as a tool very much has been a tool that was created in Sacramento County from the Specialized Treatment and Recovery Services. They adapted this tool from San Diego County that said when we get right down to it, these are the pattern of behavior that we need to have reported from the recovery service agency to the court and to child welfare. By reporting this twice a month, they're focused on the pattern of behavior. It's not the got you used. It is what's the pattern of behavior, and you used what was going on and how do we re-engage you in this change process so that you can manage your disease and be in remission. So that pattern of behavior, you see that tool that they report twice a month, it has served them well in terms of being able to establish when they need to make a change in the treatment or the case plan. All right, we're about 15 minutes from our planned end. There are many other things and items that are in the rest of your PowerPoint about resources that are available to you, as well as our contact information. If you would like to email either Dr. Hoffmann or myself with any questions, let's see if we can find out from the folks that are at Children and Family Futures. Are there questions that came in during the discussion that we can entertain briefly before we close? Someone mentions that in Florida that they see a process in place that waits for the professional assessment of the substance use disorder until there is a family plan developed and until that family plan goes to court. I'm not quite sure why that would be the case. I think it may be what we've heard sometimes is that there is a lack of trust between the parent's attorney and the child welfare agency and the treatment agency. I have been in the hallways of courtrooms in which I've heard defense counsel, parents' attorneys, or in sometimes others that have been instructing parents to not be honest, if you will, until the court requires them to be. To us, that is a question, again, of trust. It is not a question of should we be waiting until the court. When we have a timeline when a child has been removed, particularly for young children, to move quickly to permanency, and a permanent plan that's required at 12 months. In many jurisdictions, those jurisdictional or dispositional hearings are not happening until 60 or sometimes 90 days into the case. How can we possibly wait that period of time before we've responded to the disease of addiction among that parent? If you step back for just a second and say, what's happening clinically for that parent during that time period? How do we have a justification to say, let's wait 60 or 90 days before we have a response, a treatment response? Is it easy to do? In some jurisdictions, not so much. But in terms of building that trust, it takes time, it takes honesty, it takes being transparent, it takes having a value base that says, this is not about making a point or scoring a point in court. This is about the life of a child. This is about the recovery of a family, and it's about putting the family in the center of that process to say what's in the best interest of the family, because a child's well-being is dependent on the well-being of their parents, particularly with young children, in which it's so important for that relationship to be created. I have a feeling I'm talking to the choir in some cases related to this, but if the person who has asked the question about waiting until after the disposition hearing to have a substance abuse assessment would get in touch with us, we'd very much like to be able to see if we can be helpful in a technical assistance response to see if we might look at that and see if there's a way that we might help you in your community. Han, any other questions?
I think there might be one question. Maybe Dr. Hoffmann, you might be able to respond, but some of the questions that have came in are about kind of the administration of the UNCOPE, and is there room? So some of the questions are related to, should the questions be done in a verbatim fashion, and or do the questions have to be administered in the exact order of the tool?
Well, I can address that. Ideally, the questions would be verbatim, with the exception of whether you were looking at a specific substance or a generic screening. The order of the questions I don't think matters much. We have been looking at the possibility of inverting the order, starting with the E question first, especially when we're doing a screening that's a combination PTSD and substance use disorder screen, that if you ask the PTSD questions first, then starting with the have you used to relieve emotional distress seems to make a gentler transition into the addiction questions. But as to the order and whether it makes a difference or not, that's pretty much an empirical question. I don't know if anybody who's actually looked at that as to whether the order causes any substantial differences in endorsement rates.
Thank you very much. Another question is about the specifics of marijuana and the issues that child welfare are dealing with in terms of medical marijuana, and now some states that have the recreational use of marijuana. We happen to have had a conversation about this earlier just this week with some of the states that have permitted the recreational use of marijuana. And in many ways, we don't see this as being particularly different than other legal substances that can be abused and affect child well-being. If we think about the legal substance alcohol, we know that there are implications for child safety in certain ways in which that could be used. Driving in particular, that would be quite much a parallel with the recreational use of marijuana. Some of the ways in which we are looking at again, it's not the use alone, it's about how that use is affecting the parent's life functioning, about their ability to care for their child, and are there circumstances that may change based on a particular substance that change the safety factors for that particular child. So while this is new in terms of the recreational use of marijuana being permitted in some states, I don't think it's new to the safety and assessment processes that child welfare has had in place for some time. Anyone else on our team that would like to respond to that question particularly?
I would agree with that. It's not a matter of use per se, but whether the use results in certain indications that there is actually a substance use disorder. That said, one of the things we've observed with regard to cannabis is that on average, there tend to be fewer positive criteria with cannabis than with alcohol or cocaine. That is to say, we tend to see, on average, I don't remember the exact number, but a somewhat lower proportion of people at the very high end with cannabis. And that may be due to the nature of the substance. People who abuse cannabis, unlike people who misuse alcohol, do not tend to get into violent altercations and things like that. But I think the UNCOPE screen will be just about equally effective with cannabis as it is for alcohol and other substances.
Thank you very much. Another question that we'll have time for one more is in relation to the, if you will, the signs and symptoms checklist. There is a monograph on the National Center's website called Understanding Substance Abuse and Facilitating Recovery. There's a lot of information in that document that it was written specifically to frontline child welfare workers. And some of this idea of the checklist is covered in that monograph. But in particular, we've seen this implemented as a checklist in both the emergency response and the investigation phase to help workers think about what is it that they're looking for. Again, some of these are pure observations. You're going to go into the house and there's a lot of wine in the refrigerator and wine bottles. If you're there at 2 o'clock in the afternoon and there's a glass of wine on the counter, you may want to do an UNCOPE. However, if you arrive at dinner time and there's a glass of wine on the counter and there's not a lot of accompanying wine bottles or indications that would set off any kind of alarm, it may be appropriate use of alcohol. Some of those things are observational in the context of the larger allegations of abuse or neglect. It's taking in the environment as social workers are trained to do. It gives them a way to go through the checklist and say, did I remember to look for these various things? Again, some of them are clear observations. Others are things that you may put into a way of asking questions. It may be something that you look at to embed these questions of the domains that Dr. Hoffmann has been talking about today. Is that a checklist that you would create in your jurisdiction and embed the UNCOPE questions and have a way of scoring that moves that person to the next phase? Again, the changes in practice that need to be put in place and supported by a clear protocol of roles and responsibilities of child welfare and the treatment agency and the court is really the emphasis in terms of how do you ensure that that's happening for all families. How do we not have, if you will, bias in the system to say I would ask some questions of some people, but I wouldn't ask some families this because of potential bias in the system. So what is that protocol of how you ask the questions, when you ask the questions, how it gets communicated is really what we're trying to support through the idea of creating a safer model. Phil, let me turn things over to you to wrap things up today. Thank you so much, Dr. Hoffmann, for putting together the presentation. And for being with us today, for the work that you did with us over a decade ago. And Phil, let me have you wrap things up.
Thank you very much, Dr. Nancy Young, and thank you, Dr. Hoffmann. I appreciate both of your time today and expertise on this presentation. We have a few resources we'd like to highlight. There were several resources also highlighted during today's presentation. All of these are downloadable from our website. These are several of the collaborative practice model or collaborative practice monographs, some of which were talked about today. Those are on our website there. You see those. We're just going to go quickly through a few of these. One is we want to highlight for many of you is that the Family Drug Court Guidelines document, which was originally published in 2013, will be updated and available for download and in limited print copies this winter. We've done a research update. We've included more than 50 additional literature updates, and so we're excited about that coming out to the field this winter. We also have updated our online tutorials, and these are you can receive free CEUs and CLEs. We have one for child welfare workers, one guided towards treatment professionals, and one guided or directed towards legal professionals. So you can log into this on our website and receive CEUs. So we're excited about those being updated. In the spring of 2016, we'll be doing a broad launch of our Family Drug Court online tutorial. So it'll be a Family Drug Court 101 to cover the basics of what a Family Drug Court is and how they should be operating. So that's coming out soon, so keep an eye out for that. We'll be launching our Learning Academy for 2016 coming soon. So if you're not on our email list, be sure to send us your email and we can add you so that you get those dates for 2016. We have 9 peer learning courts available throughout the country. They're willing to share with you their practice and policy materials, be on phone calls with you, and share with you their experiences in running a family drug court. Also, a few other resources that are available on our website that you can get as I click through these. Again, these are all on your handouts. So where I want to end is that we appreciate your time and joining us today. At the conclusion of today's webinar, you'll be redirected to an evaluation. We hope that you'll complete that evaluation and provide us with some feedback. So again, I'd like to thank both Dr. Young and Dr. Hoffmann. I'd also like to thank the staff here at Children and Family Futures who put together this presentation. And we thank you all for your time today, and we wish you very well. Bye-bye.